are going to we are going to get started. Welcome to the space. You are here with peers and clinicians together, what we call our PACT sessions. And today we're talking about the onset of psychosis in youth. Before we get started, I want to let you all know that this presentation was prepared for intact, but please know that the thoughts, the ideas, the words that come from our presenters are those of their own. It is not a representation of SAMHSA or intact. And also this presentation is being recorded. It will be posted on our website. So if you like to rewatch and re-listen into the great things that we talk about today, you can check them out online. In case there are any security issues that happen, this session will immediately end and we will resume on a different Zoom line and we'll send you a separate email, but let's hope that that doesn't happen today, okay? I want to send a special shout out and thank you to all of our partners who make this session and sessions like these happen. You see them there on the slide. We're so appreciative of all of our partners that help us reach our vision and our services. And you'll see on the next slide that our vision is really that all children, youth, and families living with and impacted by mental health challenges have access to resources and opportunities that they need to thrive and a comprehensive and equitable system of care. All right, we get these questions pretty often, so I want to answer them for you up front. We do provide a certificate of completion. You'll receive that. If you join through phone, please contact Joanne Bloom. Her email is jbloom@cars-rp.org. You'll receive that in a follow-up email as well. So if you need that certificate of completion, Joanne is your lady. All right, you can receive and will receive the presentation after this event, and there's a recording, like I said earlier. So you can come back to this information as often as you like. Okay. With that being said, I want to welcome you all to this space. Let's make sure that we respect one another and each other's thoughts and opinions as we have this very important discussion. And I'm going to pass the mic over to our fabulous and wonderful presenters for today, Olivia and Bethany. So would you all like to introduce yourself?
Sure, I can introduce myself. My name is Olivia Hamrah. I'm a child and adolescent psychiatrist at Georgetown University Hospital. I work primarily outpatient with young adults with psychosis. And that's not just limited to young adults with schizophrenia, but also bipolar disorder and other psychiatric disorders. I also do some work in schools and consulting with primary care doctors. And I do a lot of CBT for psychosis with my young adults who I work with, and some research in the area of clinical high risk for psychosis. So I'm really happy to be here today talking to you all, and I hope we have some really good discussions on this topic. And I will hand it over to Bethany.
Hi, everyone. My name is Bethany Boik. I have a bachelor's in behavioral sciences from the University of Michigan, Dearborn. I'm an author, artist, and mental health advocate with peer lived experience from schizoaffective disorder bipolar type.
Awesome. Thank you so much, Bethany and Olivia. I failed to mention that we encourage you all to use the chat to ask questions that you might have of Bethany and Olivia. So we'll keep an eye on the chat if you have questions. And I am going to officially pass the mic back over to Olivia for the presentation. Thank you.
Thank you so much, Ashley. And again, I'm so happy to be here. I will talk for a little bit, but really the purpose of this presentation is to facilitate discussion and answer questions and make sure that you get the learning out of the session that you were hoping to get. So what I'm going to go over is just some really brief general overview to make sure that everyone's kind of on the same page and hopefully bring up some questions that you might have. Write them in the chat or save them to ask when we open it up to discussion later in the presentation. And then, of course, Bethany will also share her story, which will also hopefully bring up some questions and so we can have a really rich discussion at the end of the presentation. Next slide. Okay, so to start it all off, I just want to throw out the definition of psychosis. And I think a lot of people think of it in different ways. My most general broad way of describing it is just by saying it's really when someone has trouble differentiating what's real from what's not real, and figuring out how to approach something that is shared reality with someone else and something that they're experiencing as reality, but is unshared with other people. And so that's really what psychosis is. Next slide. And if we break it down in terms of thinking about diagnosis and how to define psychosis, it really falls into two main categories. The first one is hallucinations, which is perceiving something to be there when there's really no external stimulus, and that can come from any of our senses. Auditory would be like hearing voices or hearing things that aren't there. Visual would be like seeing something that's not really there. Tactile, feeling something. And visual and tactile hallucinations are the most common hallucinations that we see in preschool age kids. That kind of starts to shift over to auditory and visual as people get older. Gustatory and olfactory, like taste and smell hallucinations, are usually ones that we think of when we're talking about things like migraines or seizure disorders. And then delusions are these really fixed beliefs that are false, and they're really strongly held despite all of the invalidating evidence that's out there for a person. And so that can also come in a lot of different forms, but that's the broad definition of the delusion. Next slide. So when we see a young person describing something like this, like a hallucination or a delusion, the first thing that I think is really important to think about is that these experiences can be very normal. 13 to 23% of the general population endorses any history of a psychotic-like experience. So that would be like hearing someone else's thoughts, having unusual bodily sensations when no one was there, feeling like your mind is being read, hearing something no one else heard, seeing something no one else saw, feeling spied upon or followed. A lot of these things are experiences that probably many of us can relate to. And they're much more common in kids too. So a child telling you that they heard someone calling their name and there was no one really there is actually a very normal experience. Like 17% of children between the ages of 9 and 12 will report something like this. That number goes down as people get older, so it becomes more unusual as people are older. Here you see 8% of adolescents between 13 and 18 will endorse some kind of psychotic-like experience. Next slide. And then when we think about it being part of the disorder, the important thing is to then relate that experience to some form of distress. And a lot of times that's also connected with other symptoms. So in kids, most commonly when we see psychosis, it's related to depression or anxiety. But then there's so many other things that it could be related to. It could be related to trauma, bipolar disorder, so like an episode of mania with psychosis. It could be schizophrenia, some sort of sleep disorder. Lack of sleep is related to increased risk for psychosis, and also disorders like narcolepsy can come with those hallucinations as you're falling asleep or waking up. Substance-induced, medication-induced, some sort of underlying medical condition like an autoimmune disorder, encephalitis, an infection, seizures, all of these things can potentially present with psychosis. And so it's really important to know that it doesn't necessarily mean that someone has schizophrenia. It could be all of these other things too. Next slide. when we think about schizophrenia, so this is like the main primary psychotic disorder. And there's schizophrenia, there's schizoaffective disorder, which also has these mood symptoms related to it. And then there's shorter courses of primary psychotic disorders like schizophreniform disorder. These disorders are characterized by these clusters of symptoms, positive symptoms and negative symptoms. And in the positive symptom category, we see that the psychosis, so that's the delusions and the hallucinations. And then also there may be some sort of disorganized thought or disorganized behavior. And then in the negative symptoms, we have the 4 A's. So it's usually some sort of flattening of the affect, alogia, anhedonia, so not finding pleasure in things that might have been pleasurable in the past, avolition, like just lack of motivation to get out and do things. So those are the big symptoms that we see when we're talking about schizophrenia and its diagnosis. There's a lot of terms that you might hear when we're talking about psychotic disorders and psychosis. And so I also just wanted to kind of give a brief definition of some of these terms because they can get kind of confusing. Very early onset psychosis is typically described as onset before age 13. It's very rare, usually males more than females, and it indicates a pretty poor prognosis. And then we have early onset psychosis, which is a little bit more common. It's about 11% of people who ultimately have schizophrenia. And this is when the onset is before age 18. And just to give you a sense, in general, the first episode of psychosis, so that's that first episode where someone is having like real psychotic conviction and some of these symptoms, like hallucinations and delusions, that usually happens between the ages of 15 and 25. So it's like the average age range of onset. Usually happens a little bit earlier for males than females. And so then you have this term, I didn't put it in this list, of early psychosis. So it's different from early onset psychosis in that early psychosis is used to just describe these early stages of someone experiencing these psychosis symptoms. So that would be anyone with schizophrenia or again, mania with psychosis, any of these different diagnoses, but that they're in these early phases of having those symptoms. And then you have these two terms, clinical high risk for psychosis, or some people will also say the at-risk mental state, and then also the schizophrenia prodrome. So those are different in that clinical high risk for psychosis is defining a group of people who are known to have a higher risk of going on to develop schizophrenia. And they're divided into 3 categories. One is attenuated psychosis. So those are people who have kind of like unusual experiences, some like suspicious thoughts, things that may sort of be trending along the line of hallucinations and delusions, but not really that psychotic conviction, and still able to function relatively well. And then there's people who have some sort of genetic risk, like a primary relative, a first degree relative with schizophrenia or bipolar disorder, and have seen some sort of decline in functioning over the past month compared to the past year. And then the third category would be people who experience frank psychosis, but for really limited periods of times, like minutes to an hour, that then resolves. And so those people would be categorized as clinical high risk for psychosis. And about 20% of those people go on to develop schizophrenia or some sort of primary psychotic disorder. On the other hand, schizophrenia prodrome is a retrospective term. So that's looking back at someone who has schizophrenia and noticing some sort of syndrome or cluster of symptoms that they were experiencing before they then developed their first episode of psychosis. Okay, next slide. And this again just kind of shows the course of illness. So usually there's this pre-morbid phase where you don't see any symptoms. And then there's this risk syndrome. So some of the psychotic, like attenuated psychotic symptoms or some sort of functional decline. And then there's the first episode of psychosis. I think you might have to click to get the rest of the arrows on it. There you go. Okay. Go back. And The time between the first episode of psychosis and starting treatment is actually really important. We call that the duration of untreated psychosis. And the longer that time is, the worse the outcomes typically for people. So that's why there's so much effort being put into identify these people who are high risk, because if we can get them connected with mental health care, then even when if they do develop a first episode of psychosis, they can get into treatment much quicker, and that'll just shorten the duration of untreated psychosis, reduce hospitalizations, and just overall have a much better prognosis for that individual. And then the final thing I wanted to highlight is that the diagnosis of schizophrenia or schizoaffective disorder is not as, I think, dire as most people think. We kind of divide outcomes into this rule of quarters. And it shows that the majority of people are expected to have some form of recovery. 25% of people will have their first episode of psychosis, have a remission of symptoms, and then have no relapse. Then another 25% of people will have some relapse of symptoms, but will still have ties to the community, and still be for the most part, independent, working, maintaining healthy relationships. And then there's this 25% of people who still require intensive treatment and support, but their symptoms are better, and they're able to have this recovery from their psychosis. And then that last quarter are the people who really require much more intensive treatment, really aren't getting better. These are people in like residential facilities, and about 10% of people diagnosed with schizophrenia die by suicide 10 years after their diagnosis. So now so that's kind of like my general overview. I'm gonna pass the torch to Bethany, because I think one of the most important ways that we can provide better care to people who are experiencing psychosis is to listen to the people who have been through it. And so I think we've got a really great person here to talk to you about that.
Hello, everyone. So my mental health journey didn't start out with psychosis. It actually started out with depression, anxiety, and insomnia. I was 13 years old, and one night led to many sleepless nights where I tossed and turned and unable to sleep. I then started to perform poorly in school. I was an AB student that started to slip into a CD student and felt like a failure. I felt hopeless. I ended up attempting suicide in secret and was instantly overwhelmed that I didn't die, due to the fact that I had a near-death experience at age 13 when this all started. Afterwards, I became even worse. I no longer cared about my friends, my appearance. I hardly showered, and one day hit a breaking point where in a science class, I bashed my head against a lab table after almost failing a test in order to knock myself unconscious. This didn't work, however. My teacher stated I was being dramatic and that he was calling the principal's office to get me help. This made the class laugh, made me more angry, hurt, and scared. The staff then came down from the office and ended up escorting me to the guidance center in a wheelchair, where a knot grew on my head and my mom came to pick me up, as the principal told my mother she needed to get me psychological help, which she didn't think I needed before, or I couldn't return to school and Child Protective Services would become involved. Thus, I ended up seeing a psychiatrist and was placed on 3 medications. These medications, however, did not control my symptoms, and the doctor added a 4th. The additional medication caused a side effect where I ended up being hospitalized for 7 days in a children's hospital. My mom didn't want me on the medication after that, so we stopped medication, but I went to therapy. Therapy didn't help much. I remember only having my first therapist for about 2.5 months before my insurance decided it wouldn't cover that particular one. Then I had to change to another, whom I ended up feeling uncomfortable with, as they joked I might have bipolar disorder. When my symptoms got worse and I started to exhibit bipolar-like mania symptoms, where for 2-ish week periods, I dress up in costumes and decorate my clothes with pom-poms and paint. I think I'd be a famous artist and would get ideas of going around the world in various fashions. I got made fun of and laughed at mercilessly at school, but it didn't stop me from my actions. I'd stay up creating, then crash into a depression lasting months. This therapist poked fun at my symptoms and didn't listen to me when I talked about various experiences in my life and told me I was being over emotional in regards to my trauma. I didn't speak up about my pain after that for many years. Finally, in the summer, things turned for the worst. I got paranoid and I wouldn't leave the house. This is where the schizoaffective comes in. I was afraid to even go to the mailbox. I thought people could read my thoughts. I was petrified all the time. I didn't trust anyone except my grandma. I stayed in the basement, although my bedroom was upstairs, and was afraid to use the bathroom. I thought the government was tracking me. It was horrible. I didn't know what to do. I was terrified to leave the basement and hardly took care of my hygiene. I didn't talk to my friends at all during this time. I felt as if I had no control of my thoughts. For at this time, I had an episode of hearing voices. Finally, my grandma told my mom what was going on and got her to take me back to the psychiatrist, where I was put on an antipsychotic medication. This medication was very strong but helpful. I was able to go to band camp and attend school in the fall, where I was now age 14, but was heavily sedated. I slept most of the day, and at times drooled on myself on my desk. It was a terrible experience. I was no longer myself. I wasn't paranoid, but I wasn't Bethany. I lost parts of my personal traits of who I was due to the sedation. My concentration got worse, and I had a hard time doing homework because of the antipsychotic medication. The psychiatrist I had at the time didn't listen to me when I told them about the sedation for quite some time. I felt like the doctor didn't care how I felt on the medication, but being on the medication was a double-edged sword. I then tried other antipsychotics. I was put on and off many different medications with different doctors throughout high school, college, and beyond. Over 35, to be exact. I couldn't find a medication to control my depression, or a medication that didn't cause me to have severe sedation, or one that didn't cause tardive dyskinesia symptoms. Therefore, I was on and off many different medications for many years. During this time, I was labeled medication resistant 2 times, but I didn't let the doctor's labels define me and found new ones. I eventually moved during my junior year of high school and changed schools. I didn't fit in due to the fact that I didn't have the right clothes and was lower income. I got bullied a bit and decided to focus on my grades instead of social activities. I ended up getting good grades my junior and senior year of high school and attended advanced placement classes and accepted into a great college. I went to college but suffered immensely. I was in and out of psychosis. Hearing voices, commenting on what I was doing, and saying horrible things about me to me, I was suicidal at some points. I was paranoid. At times I was afraid to work and go to school, but somehow I forced myself to go through by reality checking, looking at the situation and seeing what's true and what's not. During this period, I went to crisis centers over 14 times. Somehow I survived college and went through multiple jobs in the nonprofit field, losing some, graduating, but failing to hold a job afterwards due to multiple hospitalizations and other forms of suffering. I had terrible hospitalizations. I'm thankful I had a place to go. However, I had multiple traumatic experiences at hospitals that caused me to seek trauma-focused therapy afterwards. At one such hospital stay, I was sexually harassed by 2 patients and medically neglected at one. I reported both incidents, but emotional damage is something that makes an imprint on you. During my worst psychotic moments, I had command hallucinations tell me to kill myself. I saw visual hallucinations of me hurting myself. This happened from the time I woke up to the time I went to sleep for a year and a half straight. Nothing relieved its symptoms. I tried partial hospitalization programs. I ended up getting sent back to the hospital after attending these programs. Things just didn't click. At one point, I started to lose weight quickly. When I was 22, I got down to 109 pounds. I'm almost 5'7", which doctors didn't think was bad, but mostly praised. Even though I wasn't really overweight to begin with, about 155 pounds. I hardly ate. I was afraid to leave my bedroom. I was afraid to make food in the kitchen due to my fear and paranoid ideations. I thought people were watching me outside of windows and kept my blinds and curtains shut in my bedroom. None of my doctors bothered to ask how or why I lost so much weight quickly. Now I'm overweight due to the medication side effects, and my doctor's a lot quicker to say something. At this past time, I became very uncomfortable everywhere I went. I was scared of talking to people. I fumbled over my speech. I hallucinated that other people were talking about me, saying things like they were hearing what I was thinking and that I was a bad person. I stumbled when I walked due to all the noise in my head. My life was in shambles. Therefore, I ended up applying for disability after going to a community mental health agency and being told that disability might be a good idea because I wasn't able to work. I was denied the first time. So I got a disability lawyer that visited the agency where I went to. I got it the second time. Currently, I'm on 7 medications for psychiatric reasons, but recently wrote a book that started off as a diary at age 13 called Diary of a Schizophrenic. It will be available for purchase on Amazon and Barnes & Noble May 1st, 2023. The book is not just a diary, it's an art anthology that I made through painting my experiences out in abstract art forms to explore my personal pain and other emotions. I'm proud of myself because of this book, but I still deal with many symptoms of schizoaffective bipolar type, a form of schizophrenia, because not only do people like myself deal with things like hallucinations, but we can also have severe anxiety, memory loss, and other cognitive problems from this illness. But yet I know I have achieved something. The medications I now take help, but they don't take every symptom away. I have struggles every day. Therapy helps me deal with the debilitating aspects of this illness and stress associated with it, but it has stolen quite a bit of time and life out of me. Today, I'm learning that many people, social workers, and doctors have helped me in my recovery, but some have fallen short. My current psychiatrist is an incredible individual who has saved my life by finding the right antipsychotic medication and listening to me continuously, never giving up on me. My current art therapist has changed my life for the better, teaching me how art can heal and help me in recovery and my mental health. In conclusion, I will not let schizoaffective disorder overtake me, but instead continue to live alongside this insidious mental illness. Today, I know I'm not going to be a statistic of a devastating illness, but a survivor. Thank you for listening.
Wow, can we please put in the chat just hand claps, words of encouragement, thank yous to Bethany for sharing such a powerful story. Let's take a second to acknowledge her, thank her for sharing. We appreciate you so much, Bethany. You see all the thank yous in the chat?
Yeah, that's really
Bethany?
sweet.
Yeah, so grateful for that. And while we're saying thank you, continue to please put questions in the chat for Olivia and Bethany. This is our time to have a discussion. So I see there's a question here in the chat. There's a question that asks, could you elaborate on the difference between a delusion and a cognitive distortion? So I'm going to pass that over to Olivia.
Yes, sure. And I just want to thank Bethany. Like, she is incredible. I just have no idea
Incredible.
how she has been able to push through so much, and like, it's just beautiful. So I really admire
Thank you, Olivia. Thank you, everyone. I appreciate it. It really warms my heart.
And thank you for just and being able to share that story.
Mhm.
I appreciate it.
It's helpful. But yeah, in terms of cognitive distortions versus delusions, I think the biggest thing is, and this is actually a really good question, because when I first started training in CBT for psychosis, it kind of made me realize that CBT for psychosis is just CBT, but it's a little bit trickier because delusions are so much more fixed than cognitive distortions. And so I think that's really the big difference. Is cognitive distortion is kind of a way that people assume things about the world around them and how they relate to it, and it doesn't really hold up to reality testing. Whereas a delusion is a little bit more fixed. A lot of times it's despite evidence of to the contrary, and you have to work a lot harder to kind of poke holes in the delusion. If that makes sense.
Okay, thank you for that, Olivia. Bethany, we have a question for you.
Mhm.
What is the biggest impact you think a peer or practitioner could do to support individuals who need help?
That's a good question. I think listening, being genuine, and authentic, Um, and knowing that their voice is important and their story matters and they matter. Because every single person that walks into an office has a story and they're not just a number. Because a lot of people feel like they're just another number coming into an office. And sometimes when I got care, I felt like I was just another number. And it's really hard when you feel like that and you're not getting support from someone, especially doctors or therapists. So I think when you feel like you're genuinely being heard, it makes the care more appropriate.
I love that, Bethany. Thank you. And Bethany, someone in the chat asked, would you tell us the name of your book? What is the
It's
title of your book?
called Diary of a Schizophrenic, and it's going to be published May 1st on Amazon and Barnes and Noble.
Can we give her a round of applause for that? I mean, come on, Bethany. That's awesome.
Thank you.
Round of applause. That is amazing. You are inspiring so many people in the chat. There's all kind of messages here about the inspiration you're having on folks. So
Thank
thank
you.
you.
Thank you.
Okay, let's see what other questions we have here. Let's see. I'm scanning. Okay, question for both Bethany and Olivia. What are both of your thoughts about each person having a right to their own reality?
I can go first on this one, I guess. I very much respect a person's right to their own reality. When I'm seeing someone with psychosis, what I try to focus on is goals. And when we think about recovery, it's usually related to being able to either go to school or hold a job, live independently, manage your own like activities of daily living and have healthy relationships with other people. And that's generally a pretty shared goal among most people, whether they have psychosis or not. And so I tend to work with whatever psychosis is there, rather than against it. And as long as it's not getting in the way of you being able to live the life that you really want to live, then I don't see it as a problem. The other thing is, again, I think I brought this up a little earlier, is this idea of being able to distinguish between shared reality and unshared reality. So it can be reality to you, but it's helpful to be able to distinguish the two, because then you know kind of what to do with it, and how to approach other people with it. And that also helps people achieve their goals. So I don't know, that's kind of how I look at it. But Bethany, I'm curious to hear your thoughts.
So something that I have dealt with personally is making people and myself feel comfortable in psychosis. So you can't convince someone who is psychotic that their reality isn't true. So the best thing you can do is make them feel comfortable in their own world. So making them feel like it's okay right now in this moment. And that even if you don't believe what they're experiencing is real, what they feel right now in their own body is real. So if you can make their environment around them comfortable enough because they're in distress, that's the most important thing you can do, in my opinion.
Awesome. So would you say something such as their tone? And I'm assuming, Dina, when you say their tone, you mean like maybe the clinician or therapist. Would you say something such as their tone triggered your condition? Bethany? Does tone make a difference? Does the tone that a clinician or therapist uses, does that trigger your condition?
Does it trigger like how you deal with the client with?
Well, let's ask Dina. Dina, if you are still here and you're able to unmute, can you maybe help us understand your question? Because I'm not sure if I'm saying that correctly.
Yeah, I can. Can you hear me clearly?
Yes, we can.
Yes.
Bethany, what I'm asking is when you were speaking up, trying to seek help, did you find that their tone was something that would trigger a negative response within you?
Oh,
So
yeah.
say maybe like a fight or flight kind of response, like you would then not want to communicate with them. You maybe ran from seeking help because of things like that.
Certainly, because some doctors, for example, psychiatrists and other clinicians, if they spoke to me in a way that I felt like I was being spoke down to and that I was afraid to get help from because they didn't believe me in certain aspects, then I didn't want to get help because I felt like, well, they don't believe me, so why should I talk anymore? Why should I try to get help? If they're not going to listen or they're not going to believe me and their tone of voice is negative, then why should I try to get help anymore?
Thank you for that, Bethany. I know my mom used to say a lot is sometimes not what you say, but how you say it. And so thank you for sharing that in your experience. This is a really interesting question, y'all. So in some communities and cultures, psychosis is attributed to external forces, such as spirits, and it prolongs the duration for untreated psychosis. Do you have any resources and or experience that might help families have better understanding of psychosis?
I don't specifically, I guess psychosis is something that, yes, you have to be like very culturally aware because it can be approached very differently with different cultures. Again, usually just focusing on what is important to the individual, what is important to the family, and how to work. I love how Bethany said this, how to like work with their reality. You can adapt that approach to a lot of different cultures and to a lot of different families because they can understand the fact of what's really happening in terms of like real evidence for what's happening and not just theory behind why it's happening, and then how to work with that individual to move forward.
I think basically what, like, to piggyback off of what Olivia just said, it's determining the culture and the hallucination. So, you know, you have to be mindful of what the culture is saying and at the same time be mindful of what medical practice is saying, because there's a fine line between, you know, a person's culture and, you know, different things that they believe in and medicine and medical, you know, practice. So you have to figure out, you know, what is really going on here. And you have to be mindful of how you talk to the family and how you bring up hallucinations and psychosis, because you don't want to make them feel uncomfortable when you bring those subjects up. So you have to be sensitive to those things and you know, be mindful about the discussion. So I would just be very culturally competent and sensitive to that. So I would really do some research about the person's culture and then look into the hallucinations and try to explain from a medical standpoint that this is, you know, this is what's going on here and medically speaking, and give it like an educational perspective and say, I don't think this is a cultural thing. I think this is a medical thing, but be very aware that this is a sensitive subject.
The other thing is working with, oh. I was gonna say that the other thing is working with the people in the community who are much more like very respected in the community. So even like, you know, I've worked with, when I was in Pennsylvania, there are a lot of Amish there, and like we would work with like the leaders of that community to talk about diagnosis and treatment recommendations, and then the families would like have much more buy-in to the treatment. It's like the leader of the community is on board, and then also even just like working with religious leaders can be really helpful. So those are also other ways to just like to kind of get to know the community and the community leaders, and then the rest of the people in that community have this person who they really trust also advocating and kind of on board with treatment.
I love that, y'all. And I think this next question is kind of similar in some ways. How might you handle it if a person doesn't believe their diagnosis is real?
So it's hard when you first get diagnosed. Because you don't necessarily always want to accept the fact that you have schizophrenia or that you have a psychotic disorder because of the stigma, or it could be the other way. You don't believe that you have a mental illness because of the psychosis itself. It could be playing in your head and you don't necessarily are aware of it because of the symptoms. And so there's two things that could be happening. With the stigma side of things, it's the environment and everything around you. It's very hard to deal with the stigma of having schizophrenia. I had a really hard time when I first told people I had it, and I had some friends. I got judged a lot. And I had to realize that I was either going to tell people or I wasn't. And I realized that I came to the conclusion that I was going to be open and honest, and that if I lost people, I lost people, because as a mental health advocate, I am a face to mental illness, and that my story is representative of being a person with mental illness, and that I am more than mental illness, but it has affected my life so much. I have to keep telling my story. And so I'm determined to keep going and keep thriving and keep showing that face. I know some people can't do that, but it is my job to. So that's why I'm here to do that. On the other note, with schizophrenia, some people physically can't and do not understand that they are mentally ill. And it's very difficult for them to lead a functional life because of the hallucinations and the mental process that they go through every single day. They're suffering so much. And so it's just very difficult for them. And I feel absolutely horrible for that. And I went through personal psychosis for a certain period of time where I didn't know. And it was horrifying. I literally was so psychotic, I could not differentiate my reality from the psychosis. And it was terrifying. So I know what that experience is like, and I hope to never go back. But the matter of the fact is that some people will never know. And I don't know a good answer for that particular end of the question. but there's part of the schizophrenia where you literally don't know and understand the reality from the hallucinations, so you can't understand that. But I think that you know, the hallucinations really mask a lot of the symptoms and the reality.
Wow, Bethany, I couldn't even write those gems fast enough. You were stating so many good things back to back to back. I'm going to have to listen to the recording to listen to them. So thank you for that, Bethany. Another question in the chat here. Do you all ever talk about the Healing Voices Network as an option to support recovery?
I'll be honest, I've heard about the Hearing Voices Network, but I haven't had a lot of experience with it. And I've never recommended it to anyone because I don't know enough about it.
Okay.
I'm not
Bethany
sure
or-
what that is. I'm not sure what that is.
Okay.
I'll have to Google it.
Google knows all.
Yes.
Okay, thank you for that. Okay, so let's see, we have time for maybe 2 or 3 more questions, maybe 3. All right. Did the pandemic, this is for Olivia, did the pandemic further increase the risk of psychosis for vulnerable adolescents?
That's a good question. I honestly don't know any like evidence for that off the top of my head. I would suspect that because risk is such a factor, or stress is such a factor in risk for psychosis, that the pandemic probably exacerbated that. But the other thing I know is that the pandemic did result in more people who had some form of distress from psychotic experiences not being in treatment. And again, that was something that we know is not good for outcomes of prognosis. And so that certainly it was likely to have exacerbated symptoms and distress related to psychosis, and limited the treatment options available. Even I remember like being able to be admitted to the hospital for severe mental illness was really difficult during the pandemic, especially when people were being so careful about COVID exposure. It became a huge barrier.
Okay, there are more comments there about Hearing Voices Network, but we've addressed that a little bit in the previous question. So if there are no other questions in the chat, what I want to do now is again say a big thank you. Thank you so much to Olivia. Thank you so much, Bethany, for sharing your story and being an expert in this conversation and joining us today. These sessions, and I think Bridget, she has the slides up. If you could, like I said earlier, there's a certificate of completion reporting that will be available on the next slide here. Before you all hop off, please let you know that we have these PACT sessions, these peer and clinicians together every month, or the meeting on the 3rd Thursdays of the month through August. So the next session will be about cannabis and mental health. No session in May, but we have a system of care summit. We're going to drop that in the chat. That summit is no cost to you all. It's a 3-day virtual summit. We'll have lots of different conversations about child, youth, and family mental health. So we hope that you'll join us in May for that summit. And Bridget, if you don't mind dropping that registration link in the chat, please. In June, our topic of discussion will be about positive outcomes from engaging families. July, we're talking about ACEs, and in August, we will talk about early childhood and mental health. And again, every single last one of those sessions will have both a clinician and a peer. We value peer voices at this table, so we'll have both clinicians and peers at each and every one of those sessions. Next up, again, you're invited to the summit. It's no cost, May 9th through 11th. Please register and join us for that. Great conversations that'll be happening. After this session closes out, you'll receive a post survey. So please take the post survey. Let us know what other sessions you want to hear about, what other topics you want us to bring to the table. Bridget, on the next slide, please. Stay connected with us in the intact community. We welcome you to all of our events throughout the year. You can find out more information on our website and our social media. And I think that's the last slide. Let's see. Next slide, please. Yep, survey. And next slide, please. I think that's all. That's all we have for today. Thank you all so much for joining in. As you're leaving the space, can we please just give another big thank you to Bethany and Olivia for being here with us today. And thanks to y'all. Thanks for coming. You could have been anywhere, but you're here with us. So thank you. And I think that is all for this time. We'll see you next month. Take care.
Thank you.